Um, Thank you, everyone, for joining our SAGES residency and fellow webinar. The topic today is minimally invasive hepatopancreatic biliary surgery. My name is Ismail Kandi. I'm an HPB surgeon at Advent Health in Tampa, and I want to congratulate and thank my speakers for their time and dedication to do this for SAGES. We have 3 talks that are designed to kind of cover the HPV surgery. So we have a gallbladder cancer topic, which will cover liver surgery as well, and biliary surgery, as well as a pancreatic cancer surgery. And because this is SAGES, so there will be a lot of minimal invasive talk in there. Before we start, I'm going to share a couple slides from our parent institution sponsor SAGES to let us know the mission and the vision of SAGES. So SAGES has been around for many years. I started to go to SAGES when I was an intern, and I still go to SAGES now. This is many years now. And so this is important for the residents because obviously many of residents are a junior level resident, maybe not very familiar with SAGES. So SAGES has a lot of membership benefit, and to be a member of SAGES is actually not very hard. There's a discount to a SAGES annual meeting for being a member. SAGES provides a lot of cutting edge education and professional development, and this is one of them. The courses done in Atlanta, in many different places, are also available to SAGES. It provides you with a network of 7,000 surgeons, and you can see the very, very, very famous people. You can easily talk to them at SAGES without much difficulty. For the member, you automatically have access to surgical endoscopy. So it is a very heavy, good journal for minimally invasive surgery, and you have free access to that. And SAGES also has a lot of grant and the career development award that every member can apply. You cannot apply unless you're a member. And also there is a lot of opportunity to be involved for a committee, task force, and peer reviews, and maybe one day you will become the president of SAGES as well. So the vision is reimagining surgery for a healthier world. Values, mission, you can see SAGES is very inclusive organization, a lot of innovations in there, excellence, and a lot of members from multiple continents. And most importantly, SAGES is a very fun society, especially when we meet in person again. There's always many things to enjoy in SAGES. There are 8 different types of membership. For the attending surgeon, it means that you have finished your fellowship residency, then you will fall into the category of active member that will cover surgeons in the US and Canada. And for the residents, you will be a candidate member. I was a candidate member for many years when I was a resident. When I graduated, of course, it got updated to an active member. And the medical student also joined SAGES. I've seen a lot of medical students also have the opportunity to present the podium at SAGES. So there's a lot of opportunity for education and a career development at SAGES. And this is just our most recent meeting in Las Vegas, and the next meeting will be about 6 months from now. It will be in Denver, and I'm sure it will be just as good as one in Las Vegas. So without further ado, I'm gonna start introducing our speakers here. The first speaker here is Dr. Eduardo Vega. Eduardo is a HPV surgeon at St. Elizabeth in Boston. And I know Eduardo since he was in MD Anderson years ago before he moved to Boston. And when SAGES asked me to give this talk, I picked gallbladder cancer, and Eduardo is from Chile. This is the country where the disease comes from. So I immediately know the best speaker for this, which is Eduardo. He has a lot of experience performing gallbladder cancer surgery. Therefore, he actually got pulled to MD Anderson for this. So his topic will be management of gallbladder cancer, current role of minimally invasive approach. Go ahead, Eduardo.
Yeah, thanks so much for the introduction. I don't think I deserve that, but I really appreciate Swanto the invitation, and Brian, thanks so much for the invitation. So let's share the screen and see what happens. So without further ado, we'll talk about management of gallbladder cancer. Was mentioned before, I think gallbladder cancer is different in every country, and there is some difference in geographic difference that it will worth notice. It's more prevalent and the incidence is high in South America, in Sahara Africa, and in Asia. And if we want to specify about South America and Chile, as Iswanto was already mentioned, has the higher incidence. I think this is because of the better register that we have about those cases and a specific population that has been shown to be more related to gallbladder cancer. So let's talk about what is going to be my presentation today. We'll divide it in prognostic factor. We'll talk about the technique of oncologic extent resection. We'll talk about a little bit of after resection surveillance and follow-up, and we'll finish with some conclusion. So first of all, I think I have to mention about whether this study that we did, because there is some understanding that having resecting the gallbladder um, when we suspect of a gallbladder cancer in an incidental way, meaning doing the index cholecystectomy, uh, does not drive a worse prognosis. And most of the literatures always say that the incidental gallbladder cancer has always better prognosis than non-incidental gallbladder cancer. But you have to understand that that literature has bias at that non-incidental gallbladder cancer, at least in the Western areas, has always been associated with more T4, more jaundice, and more M1 disease and R2 resection than incidental gallbladder cancer. So in this study, we tried to balance those characteristics between non-incidental and incidental gallbladder cancer. And we actually found that patients who get resected and have the tumor in the hepatic side, meaning the side that we are going to use in the cholecystectomy to remove the gallbladder from the gallbladder bed of the liver, do have worse prognosis when we do it incidentally compared to what we do in non-incidental gallbladder cancer. And you can see here in the dotted line, the T2B non-incidental, meaning we resect this en bloc, and the T2B incidental gallbladder cancer, how dismal is the prognosis when we actually interfere in the plan of resection and we do an incomplete resection of the cancer. So the first message will be, if you have suspicions of gallbladder cancer, if the technique is not present to do an oncologic external resection, you should refer this patient to the specialist who can do the oncologic external resection without without having to compromise the survival of the patient due to an incomplete oncologic resection. Well, however, most of the cancer are discovered as an incidental finding in the Western hemisphere. And it is important for everyone to understand that this is an opportunity to have information about the prognosis of that patient so you can tailor the treatment as the best you can for the specific type of patient. And we will talk about the importance of the cystic lymph node, the cystic duct margin, the complete mapping of the gallbladder cancer. Even if you find already a pathology report that says that you should have a T1B, you have to ask the pathology to review the slide of the entire gallbladder cancer, because it's not unfrequent to find a T2 when was reported a T2B gallbladder cancer. And the lymphovascular invasion, the Rokitansky-Ashcroft sinus, and also you can use the surgical report. Is most of the time in the acute cholecystitis advent or in the typical cholecystectomy, those are template, but you should try to define whether it was an emerging or an elective surgery, the approach of the surgery, whether the surgery was complete, was any perforation done during the surgery, and how was the intraoperative finding described. But the most important thing is that if you can, you should call the surgeon who did the index cholecystectomy, because from him or her is you're gonna get the best knowledge of what's going on in that incidental gallbladder cancer. So let's talk about, for example, the cystic duct lymph node. That's inform any prognosis, and the answer is yes. In those patients we study that have negative lymph node but present, they do have better prognosis than the one that have cystic lymph node positive. But that actually for everyone probably will say, well, that's expected, right? It's like an N1 disease. Well, wait a little bit. So lymph node dissection can predict the positivity of the hepatic pedicle. So we actually can use the cystic duct lymph node as a sentinel lymph node for the hepatic pedicle, but our study did not prove that you could use it for further station, like station A, 13 or 16. And thus were not predicted, and we have about 30% of the SCID metastases that actually they're not positive in the hepatic pedicle, but they were positive in either the hepatic artery, the pancreatoduodenal lymph node, or the para-aortic lymph node. And I think this is the most interesting finding of the cystic lymph node, that patients who do have a cystic lymph node positive, however, not other disease in the lymph node, meaning N0 disease, those patients behave most likely like an N0 patient. Not quite the same, but at least non-statistical different from the N0 patient compared to N1 or N2. And also, other thing you should ask to the pathology is to recheck the cystic duct margin and to try to find it, because as I show you here in this Kaplan-Meier, negative cystic duct margin compared to positive cystic duct margin, it is a prognostic cater from the index cholecystectomy clear. So let's talk about oncologic extent resection now that we talk about the incidental gallbladder cancer. And I have to remind you that you should stage those patients, right? Beside reviewing the pathologic report, you should stage the patient with either an MRI or as we do it here, chest CT and CT liver protocol of the abdomen and pelvis, with tumor market that most likely will be a C99 and CEA. So technique description, I think you will be able to access this slide, so you can actually take it from these two work. Most of the video I show you here are in the full length in those two articles. The first thing I want to show you is how you can find actually carcinomatosis or liver disease, and the important role of the diagnostic laparoscopy that is pertain to us as a minimally invasive group, because we can actually start the surgery with a diagnostic laparoscopy and complete the surgery either with either through laparoscopy or robotic surgery. But before going to that, I think before talking about approaches and minimally invasive, I think I want to highlight this study from Japan that talk about the way that the gallbladder cancer spread in the liver. You can see here that direct liver invasion from 42 patients only spread in 7 patients. So only in 7 patients from those 42 patients, and yes, there is a bias in the number of that patient, but at least it can give you an understanding how the gallbladder cancer spread. Direct liver invasion occur in only 7 patients. So I will say in the minority of the group, only push the gallbladder cancer up to the liver, meaning in those patients, probably a major liver resection will make sense, because we'll find to have this distance from the direct liver invasion. However, most of the gallbladder cancer uh, spread through portal tract invasion, meaning a combine between direct invasion and this portal tract through the portal pedicle. What it is very characteristic of biliary tract cancer, what sometimes we can call satelitosis, and metastatic nodule, meaning we have a primary and we actually have in the other side of the liver already a metastatic disease. And you can say, well, that's only in T2, T3, and maybe, greater stage of disease, but they repeat the same study with only T2 patient. And you can see in T2 patient, you could have microscopic liver metastasis positive from the other side, meaning the most important will be the biology of the tumor than, the magnitude of the resection of the liver. This is a video you can also find. I'm going to highlight here that it's very important in our cases with incidental gallbladder cancer to left this omentum in the gallbladder bed. Just like every procedure minimally invasive for HPV surgery, do an extended Cochrane maneuver that most likely involve the right colon to get exposed into the retro-aortic lymph node that you are seeing here, station 16. We usually do it routinely because we think if it is positive, we don't pursue any other dissection. And this is a cystic duct margin that we also take in the protocol of our dissection. You see here part of the lymph node and how need to be well established the protocol of the lymph node, because it's something that you have to understand. Biliary tract cancer, the key part of the biliary tract cancer is not the liver. Most of the time is the lymph node dissection. And if you review the National Cancer Database, you will understand that lymph node dissection in patient with oncologic extent resection is done poorly. And most of the patient has less of the number of recommended. The last TNM showed that the number of recommend lymph node is 6. And we have here 4 centers that has been protocolized the lymph node. This is unpublished data. And with the protocol of the lymphadenectomy, we're able to have median of 8, 4, 8, and 9.5. But this is difficult, and most likely this is the key part of the entire surgery. Here we're seeing finally the liver bed dissection with some other technique. This is clamp clutch technique with using a vasosealer. And I just want to highlight here, this is what you're going to find during the surgery, and it's very important. It's also the segment 1 of the B5 of the middle hepatic vein that is always bleed in those, when you don't follow the plane of the cholecystectomy. And we finally complete the entire liver dissection. You have to be very careful with this move here, because here you will see one of the pedicle of the bile duct from the segment 5. So be careful with that, because this is the apex of the cone and it's very technical, and you can easily get damage of the bile duct and then get a bile leak over there. This is a study we did between open and laparoscopic, and you can see that this is the first study who trying to weight the approaches, because we know that they're different in disease, amount of disease of the patient. So we have to match in some way, and the way not to lose in any patient is was with inverse probability treatment weight analysis. And this was published in British Journal, and the Kaplan-Meier looked no survival different between those. So laparoscopic not inferior. And when we see the relapse, the recurrence, that it was something that we were curious about it. we found that when we stratify by residual cancer, there is no difference between open and lab. Again, this about the port extraction of the laparoscopic, I think there is better evidence than the study I present here. I think there is a study from Marker, and there is also a study from Cecilia Etun that they did actually take a deep look into the need or no need of port resection, and the conclusion is we don't need port resection. And I can show you here in the pattern of recurrence from the lab versus open. You can see more recurrence, more carcinomatosis in the open, and that means not that open is worse. It means that the amount of disease that was involved in those open patients was significantly greater. This is the carcinomatosis you will see, and that's the reason why diagnostic lab makes sense in gallbladder cancer. This is very, it's a hard type of disease to find in preoperative imaging. And can it do it with the robot? Yes, it can. We're going to show you these two imaging. I think is could be well done, the lymphadenectomy with the robot, and I will say some surgeon will say that is even easy than laparoscopic with the help of the robot. And here you see the liver dissection. I think for our taste right now is a little bit burn. I hopeful that we improve this technique. Yeah, so far. Again, I want to stress that the amount of resection, it doesn't pertain a better survival. And in the old series for our study, we used to do common bile duct resection because we thought that it's going to improve the lymph node dissection. But as Ben showed also in other studies, the common bile duct resection itself, it doesn't actually make it any better for the patient. Indeed, gut is associated with more morbidity. So the last thing I want to mention is the follow-up of the surveillance. And the most important thing you have to understand is what it's called residual cancer in the incidental gallbladder cancer. We have residual cancer, we're talking about cancer we found either in the local or in the regional area. And we think because of this study, we compare patients from MD Anderson and patients from Sotero del Rio, Chile. We think that residual cancer is the worst prognosis that you could have in incidental gallbladder cancer. And thus is not only in every patient, but also in very good prognostic patient like N0, R0 patient, that the survival is a kind of stage 4 disease. Recently published this study where we kind of measure the recurrence and the likelihood of having a recurrence. And you can see here the 80 months is the number when you have the most of the recurrence in the gallbladder cancer. But this is the most important part of the graphic. If you stratify the likelihood of recurrence, stage 3 and 4 has the greatest likelihood of recurrence compared to stage 1 and 2. And that means that those patients, we have to be very careful, and those patients will benefit from adjuvant treatment, while those other patients most likely will benefit from a long period of 6 months of surveillance instead of being 2 or 3 months of follow-up. Adjuvant chemotherapy. So we have 3 randomized trials that are important to know. The ABC trial for unresectable biliary tract cancer with 36% of being gallbladder cancer. And you can see here that it is significant, although the median survival was about 5 to 6 months greater. Then we have this French trial, the project, is published in Journal of Clinical Oncology, did not find survival advantage in patients who had resectable biliary tract cancer, 20% with gemcitabine oxaliplatin. There is a different explanation for this. They think, I think the series of this study has better prognosis with less R1 margin and less N positive patient. And also you may say it's underpowered because it didn't have enough number of patients for arm. Then we have this build cap. However, build cap, everyone cited in biliary tract cancer. For gallbladder cancer specifically, only 80% of the patient had gallbladder cancer, and they include, and that's what they put in the protocol, they include gallbladder cancer that were muscular involved, meaning that could be T1B. And I think it's very unlikely that we can actually help a T1B cancer from a gallbladder perspective, from the adjuvant, from the chemo perspective. So I think we'll still have a lot of work to do. And kudos to Emory University, because I think this is the most exciting trial we have for gallbladder cancer. It's been done here in the United States. There is most of the hepatobiliary center that are well known in United States are involved in this. And I think Emory University is leading this with Dr. Matei. So we hope this is going to get some good information about it. And conclusion, most common presentation of gallbladder cancer is incidental. Prior non-oncologic surgery for gallbladder cancer, meaning index cholecystectomy, affects survival. Status of the cystic duct lymph node predict D1, portal pedicle, but not anything else. So we have to do a complete lymphadenectomy. A staging laparoscopy help. Most of the armamentarium we have today is just the surgery. So you should do a high quality surgery with a good lymphadenectomy. That has been the most significant part of the dissection. Resection alone is insufficient in patients with residual cancer and with advanced stage, and we should start tailoring the surveillance by stage for gallbladder cancer. This is going to be, so I recommend those paper. I think they're well done, and it's also pertain for the gallbladder cancer. And I would want to thank Claudius Conrad, Eduardo Viñuela, and Marcelo Vivanco, who had helped me to develop in this field of gallbladder cancer. Thanks so much.
Thank you very much, Eduardo, for such a excellent, very insightful talk. And I know you have a lot of knowledge about this disease, this operation, the adjuvant treatment and everything. So for the interest of time, we're going to finish all the talks, and we'll do the questions at the end. I took notes for the questions, so we will address the question once the third speaker is done with the talk. And again, thank you, Eduardo.
Yeah.
We are going to go to the second talk. The second talk will be given by Subhashini Elu. Subhashini is a section chief of HPV surgery at Brown Surgical Associate. Subhashini, I know Subhashini when she was at Rutgers before. We work at many SAGES committee, and Subhashini always give good advice, very technically good surgeon. And Subhashini is going to give us a talk about surgical option for common bile duct stones. My GI docs cannot remove it. Now, what do we do? And this is a very common consult for the residents, and we deal with this every day. So, Subhashini.
Thank you, Dr. Sukendi, and I would like to thank the resident webinar committee members for giving the opportunity to talk on this topic. First of all, is the audio okay? Everybody can hear me? All right, good. So my talk is much peaceful than the previous talk, which is about cancer operation. This is much more fun, actually, common bile duct stones. I can understand why Dr. Sukendi chose me to talk on this. I'll tell you in a few minutes. So the talk is surgical options for common bile duct stones when my GI docs can't remove it. I don't have any disclosures. So as I mentioned before, I know exactly why Dr. Sukendi has picked me to talk on this, because this is the paper that I authored just a couple of years ago with all the most current data we have on this topic. I would highly recommend this paper because for one reason is when I was going through my training and even early part of my career, well, this is a given question in mock orals for the board exam, number one. Number two, other than saying the first basic 1 or 2 steps, if the examiner probes further, we tend to go blank, especially as general surgeons, unless you specialize in HPB, what to do. So this paper is a very technical. It's like a operative manual. That's all I want to say about this. So when non-surgical options are unsuccessful, how do we address common bile duct stones? Well, just if you would have, I don't think anybody would have asked me to talk about this topic a few decades ago, because this was a surgical problem. The surgeons handled this topic of stones in the bile duct, impacted stones. And we didn't, frankly, we didn't have ERCPs. So this was purely a surgical issue. Just like any other surgical patients, we would like to go back to our basic and evaluate the patient, prepare for the pathology, how do we address, and what procedures can we offer. But unfortunately, there is a surprise. Most often, we don't go prepared for this pathology because 10 to 15% of symptomatic cholelithiasis, where we are thinking we would just go in and remove the gallbladder, but those patients will have concurrent choledocholithiasis. So it's usually a little bit surprising. And most often you'll find...
Subhashini, I'm going to interrupt for a few seconds. We cannot see your screen. Can you share the screen on maybe,
Vera, can you share Vera? The screen? Okay, good. Perfect. So let me, thank you for mentioning that early on. So I was just referring to, I don't know, I don't see you moving in your screen, on your screen. This third slide. Okay, next one. Okay. Let's go to objectives. Okay, so just like any other patients, I think, we will start out with simply evaluating the patient, preparing for this, and what are the procedures that are available to us. But there is always a surprise. Next slide, Vera. There's always a surprise. 10 to 15% of symptomatic cholelithiasis patients will present with concurrent choledocholithiasis. Most often we miss it. Otherwise, we could say, well, I have done last 100 gallbladders. I haven't done 15 common bile duct explorations. That's because we, most often we don't find it because we simply do the cholecystectomy and then go from there, unless the patient represents or if you're doing an intraoperative cholangiogram or an intraoperative ultrasound, you might find it. So if one was thinking about cholecystectomy and doing a concurrent IOC or IOU, then what do we do if you find these stones? Well, it depends on the surgeon's experience and competence. You can deal with this pathology in 1 stage or 2 stages. They both are equally effective. But in the single stage where you do a cholecystectomy and at the same time do a laparoscopic common bile duct exploration, it's much better than 2-stage procedure where most often in current situations without training and competence, we tend to either do a pre or post ERCP, and that becomes a 2-stage procedure. And usually it's never a single ERCP. The patient will end up having multiple ERCPs, stent placement. So even as an outpatient procedure, it still becomes expensive and the length of stay is prolonged and it is associated with higher morbidity. So if we can, we like to take care of this problem in single stage. Next slide, Vera. So if this is a busy algorithm, but stay with me because I'm going to simplify this very nicely. If this slide has been prepared to account for pretty much every case scenario that most probably is going to hit in your practice, or at least most of it. Let me put it this way. But let's take a simple case. If you look at it, you're suspecting choledocholithiasis. Some things that should go on immediately is, you should be assessing, how many are there, what size are there, where are the stones, what's the biliary anatomy, what is a surgeon's experience, what are the technical resources do I have in order to address this. So let's take a simple pathway. On your left-hand side, if you're thinking about choledocholitis, is the gallbladder still there? Because you might have this situation without having the gallbladder. So if you go down the left side, if the bilirubin is less than 1.75, or it's the transient LFT increase, then you can do a laparoscopic cholecystectomy and intraoperative cholangiogram, and you can follow the pathway. If there are no stones, the patient can go home. If there are stones, you can think about doing a transcystic exploration. And if that is successful, again, the patient goes home. If that's not, then you might have to go to the main bile duct exploration. Well, if you go on to the other side where the bilirubin is elevated and the bile duct is dilated, then you have an option. One could get an ERCP before going to the operating room. And if they are not able to successfully remove the stone, then, you should think about laparoscopic cholecystectomy and transcystic or main bile duct exploration. The other option, if that is not for any reason acceptable for patient's case scenario, then you can think about percutaneous transabdominal drain. But most often, outside United States, people think about single stage. They would take the patient to the operating room, do a laparoscopic cholecystectomy, and do an intraoperative cholangiogram, and then try to remove this stone. Let's go to next slide. This is the basic instruments one should at least have before venturing into this. I only put down the main essential items that might be required, but again, I'm referencing you to go to the paper that has pretty much very detailed what size of the guide wire you need. Like I mentioned, it's an operative manual, that paper. So you should have at least a fluoroscopy, choledocoscopy, and Fogarty's. I would recommend vascular and biliary if you're thinking about minimally invasive approaches. A feeding tube, definitely needed, but even if you're not able to get the stones out, leaving a feeding tube is like the safety net that will help you further down in other procedures. And the other things, baskets, stents, irrigation catheters, and ICGs. Let's go to the next slide. Most often for these procedures, whether I'm doing a simple cholecystectomy or exploring the bile duct for stones or even resecting for strictures, this is my main setup. Usually I approach this in minimally invasive approach using the robotic platform that comes from, this is done for SI, but XI is the same way. It comes from the cranial side of the patient, the surgeon in between the legs, or the first assistant rather, and the surgeon at the console. This is like the basic setup for this. Can we play this video, Vera? So what is the patient position? Usually these patients are positioned supine with arms tucked, and then I put them in reverse Sternberg, the anesthesia at the cranial side. There's a Foley, OG tube, the scrub tech, and this first assistant on either side. The whole abdomen is prepped and draped to account for any conversions to open. And pretty much this is my basic procedure. If you want, you can have a parted legs depending on how easier it is. Let's go to the next slide. So how do I enter the abdomen? Let's play this. Usually we obtain a pneumoinsufflation in the left upper quadrant. Once we obtain the pneumoinsufflation with the needle, what we do is, can you mute the video, Vera, please? What I do is I enter with a 5mm trocar pretty much in the periumbilical area, and what I do first step is look around, see what I find initially before I insert all the other trocars. Now, if I see, sometimes you won't even be able to see the gallbladder, or you'll see the whole omentum retracted up into the right upper quadrant. then you know that you have a little bit of work to do, because that means either the infection or inflammation is being contained by all those. Those are like, there is a little bit advanced. And then what I do is I put an 8mm trocar to the left mid abdomen for the fourth arm of the robot, and then 2 other ports on the right side for the left arm of the surgeon. And then whatever the 5mm that I use to enter, I switch it to 8mm. So essentially, I'll use all 4 arms of the robot, and I'll have 1 additional assistant port to help me with retraction, or if I need any irrigation or suction. With the most recent generation robotic platform, you can use the suction. In older generation robotic platform, you need that assistant port to bring in the suction catheter. Let's move on to the next step. So what do I do first initially? Like I mentioned, initial thing is to inspect what am I seeing, and then you can do a palpation of the common bile duct, 6 structures. You can do an intraoperative ultrasound if that is in your armamentarium. And then you can do a cholangiogram. So how do I expose the common bile duct? Well, although this is a very basic step that we do innately, it's important that when you're beginning, with the pathology going on, it's you forget the basic things. Once you put the patient in reverse Sternberg position, retract the gallbladder up cranially, and then pull down on the duodenum or the stomach, and that brings up the common bile duct anteriorly so that you can see all the structures there. And let's play this next video. This is the port entrance. This is usually how I position my trocars. Once I enter it, with the robotic platform, I'll grab the fundus and retract it and see if I can visualize all this structure. I put a very easy gallbladder case so that you can appreciate how well you can see the common bile duct, really the junction of the infundibulum, the cystic duct. And then as you retract up cranially, same principles as laparoscopy, it brings up that common bile duct up nicely. I mean, even without dissecting any peritoneal reflection, you can see the structures very clear. Most often you may not have this kind of situation, but to understand the basic anatomy, this is a simple case to use it. Let's go to the next slide. So, the next step would be to palpate. If you are doing this in an open approach, then the surgeon's left hand in the foramen of Winslow, the index finger in the foramen of Winslow, and the thumb on the common bile duct, you're palpating, feeling for any stones. If you have a stent already, that can help you. If you have a cystic duct stump, that can help you. Each structure can guide you at what you're doing, because although this slide looks very simple, you might be in situations, this whole area might be frozen. So bimanual palpation will become very important exam in your management. You can do an intraoperative ultrasound, especially if there is bile duct inflamed. You'll see the thick duct wall compared to the portal vein, which will look very thin. Next slide, Vera. Which will look very thin. As you can see in both of these intraoperative ultrasound, the thick common bile duct with the stent in it on the left side, and then same and on the right side in a patient with cholangiocarcinoma, you can see how thick that bile duct wall is. Let's move on to the next slide. And if you're thinking about open procedures, the next step would be, you evaluate it, you palpate it, do a cholangiogram, and this is something you have to know, your OR, your staff, how your OR orientation, how you want to position the patient to get the C-arm in real quickly and then easily taken away without much of major disruption. And you also have to kind of have your setup with the catheter, 3-way stopcock, And if for any reason, you can't get a cholangiogram with that regular size cholangiogram catheter, then just take a 21 gauge butterfly needle and try to aspirate. If you get bile, you're in the bile duct, you can shoot a cholangiogram through that. It gives a decent picture. Let's go to the next slide. So what's the step one? Step one is, this is where, as a resident, at least we would answer this part, and then we don't know what to do. So I want to start with where we know, so that we can move on to the next advanced step in addressing this issue. So relaxing the sphincter. So you can ask your anesthesia colleague to give 1 milligram of IV glucagon. You have that cholangiogram catheter, try to flush with saline, warm saline. You can use your fluoroscopy to understand what is going on, where the stones are. Now here, when you're doing cholangiogram, you're not just looking for the stone, but you're also understanding the anatomy, because the next step for you would be, if you find the stone, how do you want to remove this? Do you want to do this transcystic or with main duct exploration? Why is that important? It is because most often we wish the cystic duct is coming on the patient right side, inserting on the main bile duct nicely, like in figure A, and at a nice angle. But most often that is not the case. You have variations in the cystic duct insertion to the main duct. As you can see in B and C and D, it's left-sided. Not B, C and C, D, and E, it's the left-sided insertion. One is coming anterior to the main duct, the cystic duct, and then one is posterior to the main duct. And the B is running all the way along parallel to the main duct before inserting. And the F is even worse. It's like inserts into the hepatic duct. So it's important to understand this. Let's move on to the next slide. So I can tell you some way guidelines of which method you want to choose, but essentially, if you're choosing a transcystic common bile duct exploration, it's the ratio of the size of your cystic duct versus the size of your stone. Obviously, if you have fewer stones, smaller size stones, maybe transcystic is a good approach. Especially if you have that right-sided insertion of the cystic duct without having that cystic duct being tortuous. But if you have a larger stones, most often we'd say 1 centimeter, or if you have variation of the cystic duct insertion, or if it is recurrent stones, then maybe transcystic may not work, and direct approach to the main bile duct exploration might be the best option. Again, here, you have to think about the resources that you have at your facility, and what's the experience of the surgical team. So all these factors go in making a decision whether you want to do a transcystic or main bile duct exploration. Let's move on to the next slide. So that's step one. Step two, if you're considering transcystic approach, what I recommend is, usually when we are trying to remove the gallbladder, we make our incision at the cystic duct very high up, close to the gallbladder, trying to stay away from the main bile duct. But here, if you're thinking about transcystic exploration, it might be better to go closer to the main bile duct. Again, just because I said that, don't go very, very close, but give yourself a little bit buffer. But what it does is it avoids all those spiral valves in the cystic duct, which impedes that stone coming out. So, giving yourself a little bit buffer to have that little stump, but close enough, will give you a little bit much more easier way to remove those stones. And you can use a guide wire, and you can use a balloon dilating catheter. You can dilate the cystic duct if you have the pneumatic dilator at your disposal, and dilate the cystic duct and try to remove the stone that way. Next slide, Vera. One of the things that I would, let's play the video. So one of the things that I would mention is, most often what people do is they'll dissect the gallbladder and then they'll remove the gallbladder. What I suggest is don't remove the gallbladder, take it all the way to the fundus and leave it up there, which you can use it for retraction cranially, and then that will leave the cystic duct and the main bile duct exposed for you very nicely. Use that as an anchor to lift it up. Now you can see the cystic duct and the main duct clearly. Now, most often, unless you also do endoscopy, most people don't have a pneumatic dilator in the operating room. If that is not the case, even though it is not recommended, I just say, place a small Fogarty and try to see if you can still dilate that cystic duct and see if you can milk out any small stones that are there. I mean, as long as you're doing it gently, I don't think any harm is done. Let's move on to the next slide. Most often, this is the situation in my cases. You can see this is a jaundiced liver. Somebody has already taken out the gallbladder. You have a dilated cystic duct. And I take advantage of that. I don't go, even though I know the gallbladder is gone and transcystic exploration in this person may most probably not be effective. Well, I still, spend some time in exploring through that cystic duct. One, it gives me an idea of the anatomy of the cystic duct insertion to the main duct, and if there are any stones, sludges in the cystic duct, you can remove it. You can irrigate it out also, so you can. And no harm done, because that cystic duct stump is not doing anything right now. You haven't touched the main bile duct. So I'll be even a little bit rougher here, try to see what I can find. And that's the luxury of using that. So exploit it to your advantage if you can. I think that, this, even if you're not trained in doing an main duct exploration, you can do this. You can still, do a transcystic approach. Now, one thing I'll tell you is, if for any reason you have done the transcystic exploration, the stone is still there, you're not successful of removing the stone, what I would advise is at least take a feeding tube or a 5-French ureterocatheter and leave it in there. Can we move to the next slide, Vera? So what does it do? Well, this is the thing. You are thinking that if you can't remove the stone, that the GI doctor post-procedure is going to remove the stone with the ERCP. Well, if they can't access the ampulla and the bile duct, they won't be able to remove the stone either. And then you're going to end up with doing a percutaneous drain, which is very morbid. So what I suggest is leaving at least a ureterocatheter or a feeding tube catheter into the stump of the cystic duct. That way, what you can do is later on, you can place a guide wire and go down, go and pass it through the ampulla, and that gives a much more secure access through the ampulla into the main bile duct for the GI doctor. So that's like a safety net. I think you should at least consider. It's not a complex maneuver. You take a feeding tube catheter, place it inside the cystic duct. You can tie it with a chromic suture and leave it there. Okay, let's move on to the next slide. And let's move to the step 3. So we went from transcystic, now we are going into the main bile duct exploration. My position of trocars doesn't change, like I mentioned, for any biliary procedures or right-sided liver procedure. This is standard port placement. Let's move on to the next video. And if I'm using the ICG Flores, if I'm using the robotic platform, I'll take advantage of using the ICG just like cholangiogram. I find it using ICG much more user-friendly because I don't have to bring in a C-arm. I don't have to depend on a technician to come with it. I don't have to move my operating paraphernalia in the operating room. This is done by just injecting ICG. Usually the bottle comes with 25 milligram. You dilute it with 10 ml of sterile water. That's 2.5 milligram per cc. I'll inject about, with the XI system, it's very sensitive at anything like 0.5. It gives good visualization of the biliary structures. And this is, ICG has very, very low risk of any kind of side effects with it, because people might have allergies to contrast, and this doesn't, and no time wasted in moving things around, bringing the C-arm or positioning the patient. None of it. It goes through the IV and you'll see the biliary structures. You know, I usually give it about when the patient is being rolled into the operating room from the pre-op area, or even if I forget to do that there, I'll just do it intraoperatively. It's pretty quick. Within about 20-30 minutes, you'll see the ICG in the biliary structures. And do I, you know, not just for looking at stones or any aberrant anatomy, I use it even when I'm doing a simple cholecystectomy, when I know there's no stones, no impacted stones are there now. It just gives me reassurance, additional reassurance that the structures that I'm dealing with, I'm very sure. So it, you know, cholangiogram has been replaced pretty much in my practice with the ICG. I put this one, this patient, actually, I did not do a bile duct exploration on this patient, but the reason I put this is you can see the ICG, you can see the anatomy very well. This is a thin, floppy gallbladder, but then you see something horizontally just below that, that fundus of the gallbladder. And then I'm explaining, since I'm working at a teaching hospital, I'm explaining all the structures, and all of a sudden I see this pulsatile structure in the middle, very close to the gallbladder. You can almost like go through it. And so one of the things that's nice with the ICG is, unlike the cholangiogram, which only looks at the bile duct structures, I can inject additional ICG very fast. And if it is any vascular structures, it will light up very nicely. So I know that there is a important critical blood vessel that I should avoid there. You know, there is a lot of variations in this area, so one has to be cautious. Cautious when they are dealing with this. I'll just let this video play for another 30 seconds just to show you how cool it is that you don't have it with the ICG. You can look at the biliary structures and you can look at the vascular structures, unlike the cholangiogram. So you give a rapid infusion of ICG, very little, 1 cc, and you can see the contrast going into the blood vessels. You can see how it's lighted up right now. So that's the cool thing about ICG. I don't use it just for the stone cases. I use it pretty much in any biliary or liver cases. Let me move on to the next slide. So most often, that, you know, so far I've showed you simpler gallbladders, but can you mute this, Vera? So most often, you know, when we are dealing, at least when it comes to my table, the inside looks like this. The liver, the duodenum fused, and the porta hepatis is really frozen. I don't know where the arterial structures are, where the duct is. You can do an ultrasound. But one of the nice tricks is take very small needle, like a butterfly needle, just cut off the wings of it, and then you can pass that needle through the trocar, and then I'll insert and see what I'm getting. Am I getting an arterial blood, venous blood, or the bile? And that tells me what structure I'm dealing with. At least it gives another clue that before you make an incision there, that, okay, you're dealing with the biliary structure. Most often the cases that I deal with, you know, it looks like this. Let's move on to the next video. What I do is, you know, even though if you have, like I mentioned, if you're doing open, you can use your hands to can be pause, silence the audio. What I do is I go very slowly on, since now I know I isolated that is the bile duct with that small needle with the bile coming out. I'll go very gingerly, take my time, very small incision, because even if I'm entering a different structure, no harm done. With one figure of 8, I can always close that. So I'll go very gently and see what I'm getting. Next video, please. And then this is something that I used to do. I don't do it anymore because I don't find it. I think I passed the stage of using stay sutures. But initially in my cases, I used to pretty much replicate what I was doing in open surgery. So I would put a stay suture and use the fourth arm of the robot to retract it. By the way, if the fourth arm is retracting the sutures, then how am I retracting the liver? Most of these cases, when you go in, have adhesions of the liver to the anterior abdominal wall. I don't take those out. I let that help me in retracting and exposing the porta hepatis. But this is another one. I mean, even if you're beginning to do these cases and you want to replicate the way you do the open surgeries, you can put a stay suture on it. Let's play the next video. And then what I do is I take a 5 French Fogarty and pretty much go through my choledochotomy and try to see if I can extract any stone. You see, I left the cystic duct stump as is. I didn't close it with a clip because if for any reason I need to access that, it's available for me. But because I can even close this main choledochotomy with a clamp and shoot a cholangiogram through the cystic duct stump if I need to, or I can put a drain through it in case if I need to leave a drain. So I leave that alone. I don't clamp it. And then essentially what I do is I take a Fogarty and then go into the bile duct, main bile duct, and try to remove all the stones. One of the things I have to mention is if you're doing open, yes, the biliary Fogarty is good enough to remove all these stones. But if you are doing this with minimal invasive approach, whether it's laparoscopy or robotics, the biliary Fogarty is not, doesn't have enough length to reach. It might reach proximally, but distally, it may not. And even proximally, if you're going into deep into the liver, it may not. So use a vascular Fogarty. So that's another thing. You have to make sure that it is there in your armamentarium, because usually that's in the vascular section of the OR, not in the biliary side. So, and also they have irrigation catheter, the same length. I usually take those and use it in my cases. So these are not in the biliary Fogarty sections. So let's move on to the next video. So once the stones are extracted, I don't know if you paid attention that I do a cholangiogram through that, and then the cholangiogram, if it shows that all the stones are removed and the contrast is flowing freely, then I just do a primary closure of that choledochotomy. Now this I have done multiple ways. I don't find any difference which technique is best. You can start from top and then bottom and meet in the middle, or you can start one corner and then run it all the way up. It really doesn't make any difference, because essentially that choledochotomy you're looking at, it's like maybe 1.5 centimeter or less. And that's the beauty about it, that I find, these instruments are small, tiny. You're able to reach all those areas and still remove multiple stones through that small choledochotomy. Now, let's go to the next video and have the volume up on this one. This is important. I put this video in because most people don't know how to fashion a T-tube. And if you're not able to remove all the stones through the main bile duct, think about leaving just a regular feeding catheter, like I mentioned, or maybe T-tube as a last catheter. This is my least favorite, but you should know how to make it. It's not playing, Vera?
No, I just stopped.
Okay, well, we'll move on to the next one. For next one is also a video. Let's play the next video. All right, this is also a video. So essentially, I want to summarize what we talked about. This is a case, patient. This is a third episode with elevated LFTs. She is gram-negative positive. She had a Billroth tube for a duodenal mass, essentially coming with a dilated duct and an impacted stone that you can see. And then what do we do? She already had an ERCPs a couple of times and was unsuccessful. Well, pretty much this patient has nothing else to do other than take her to the operating room. And if I can, I'm speeding up that video as a lot because for the sake of time, but you can see I'm needle localization, and then I, do my choledochotomy, use my Fogarty catheters to remove the stone and do a completion cholangiogram, and initially cholangiogram to evaluate, and then completion cholangiogram. And if all the stones are removed, then I do a primary closure of that choledochotomy. That's like a quick rundown of an entire case, this video. Okay, let's go. Let's move on to the next one. If you can silence the audio. So sometimes these are extreme situations. Sometimes you don't have the option for primary closure of the choledochotomy after there are still stones left, or that the patient has recurrent stones. Then think about a hepaticojejunostomy or a hepaticoduodenostomy. How are we doing on the time, Vera?
We're okay, I think.
Okay, so so you can see this is a standard root creation that I do. Use the I used to use the harmonic. Now we have a synchroseal that we use, make the enterotomies, use a stapler, side-to-side anastomosis. And then I'll just close the common enterotomy in 2 layers. And then take my rule up, my jejunum up. Usually anticolic, you can do anticolic, retrocolic in any way.
It looks like the video is not running.
Oh, it's okay. I think, the point that I wanted to mention is that's like, if you have done transcystic and then main bile duct exploration, and still there are cases with especially sickle cell patients or patients who are prone for recurrent lithiasis, that, a one-time exploration is not going to fix their issue, then you should think about doing a more permanent solution for them, which would be an hepaticojejunostomy or hepaticoduodenostomy. Now, those are the next 2 videos that I have. If it doesn't play, that's okay, but I just wanted to mention that. The third point that I wanted to mention is sometimes you will have cases where the stones are in certain segment of the liver. And in that case, I have a patient who already had a hepaticoduodenostomy done still formed recurrent stones in the left lobe. In that case, you might have to even do a liver resection. Those are the next 3 videos that I had. If it doesn't play, that's okay. Does this video play the open choledochotomy, Vera? Yeah, this is a nice video. I don't do much of open these, so I borrowed it from Virginia Mason, and it's a nice case of how to do a open choledochoduodenostomy case. And I had it another video doing it with the robotic platform just to show you the difference view of different approach, but though both are acceptable procedures. You can see how they put the sutures on the anterior wall retracting up, because usually the intuition is we always start the posterior wall, but it's actually the anterior wall. If you do that, it nicely pulls up that bile duct, and then now you can work on the posterior wall of the bile duct. And you can see the bullet suction. That's important. The regular Yankar might be too bulky here. And one of the other things that I like that they use the wound protectors, because you're dealing with, usually most of these cases, you end up breaking the stones and there are sludge and the stones are everywhere. So it's another nice trick to keep the area more contained. So let's go to the conclusion slide, the last slide, Vera. Next one. One more. Keep going. There. So, what do I want the take-home message? The take-home message is, 10 to 15% of symptomatic cholelithiasis is concurrent common bile duct stones. So you have to have some plan or strategy how you want to deal with it. And in order to, it's very individualized. I can't just give you a cookbook because it depends on just not you. It also depends on the hospital resources, how your surgical team competence is, and then your own experience and comfort. So those are all depends in, and also whether you have the hospital resources, which includes the GI and all the other people. This is a surgeon's problem. It's a surgical issue. At the end of the day, when none of the other techniques solves the problem, then you have to deal with it. If you're not comfortable with exploring the main bile duct or doing the advanced hepaticoduodenostomy or hepaticojejunostomy or liver resection, the least you can do when you do the gallbladder is you have the cystic stump, leave a biliary place a feeding tube or a ureteral catheter in there, because then even if they failed the ERCP before, because of that catheter, you can pass a guide wire all the way down into the ampulla, out of the ampulla, and then the endoscopy, when they go the next time, they'll be able to see that wire, and then they can do a rendezvous. So that is the best advice I can give you in these situations. And then like I mentioned, do a cholangiogram, see which approach would be best. Transcystic, that is simple enough. I think anybody can do it. You really don't need a pneumatic dilator, even though that will improve the success rate of removing the stone. You can use a Fogarty catheter also, at least for the initial basic maneuvers. And then if that is not successful, then if you're comfortable, You can do a main bile duct exploration. And if the stones are still there, leave a drain in, whether it is just a simple drain, transcystic drain, or choledochotomy drain, or a T-tube. It's up to you, but at least by leaving that, what is important is it's not the stone that's causing the problem, it's the blockage. So at least you'll relieve the blockage, and then you'll provide a access for other interventionals, such as GI or interventional radiology, to go in and at least help us in that problem. Well, thank you for your time. I'll take any questions at the end.
Thank you very much for the excellent and as expected, a lot of technical details of the talk, and this is obviously important for our residents to know what are the options and when to send to the HPV centers. For the interest of time, we're going to move on to the third and the last speaker for tonight. It is Dr. Melissa Hoke. Melissa is Director of HPV Surgery at Northwell. Melissa and I, we worked together in Pittsburgh. Melissa actually taught me how to do robotic Whipple when I was in Pittsburgh. I come every Sunday to learn how to sew the bile duct anastomosis, and I really learned a lot from Melissa. And tonight she's going to talk about state-of-the-art minimally invasive pancreatic surgery for pancreatic cancer.
Excellent,
Melissa.
great. Thanks for that nice introduction. Can you hear me okay, Aswanto?
Yeah, perfect. Okay,
excellent. And I do have disclosures, an old SAGES grant, and then I teach some courses for Intuitive. So today we're going to talk a little bit about discussing the classifications and approach for pancreas cancer. So that's the first and foremost before getting to the operating room. And then we're going to talk about some technical pearls of the robotic Whipple and the robotic distal pancreatectomy. So, the pancreas is made up of all kinds of different cells. So when you have a solid pancreas mass, your mind should go to, is this a ductal cell? Is this an acinar cell? Is this a islets of Langerhans neuroendocrine cell? And sort of for the content portion of the discussion, we're going to focus on adenocarcinoma. And unfortunately, we know adenocarcinoma of the pancreas is just a bad actor. It's the third leading cause of cancer deaths, first cause of mortality. 92% die within 5 years. 74% die the first year of their diagnosis. 55% increase. And there's not really great early detection, although the NCCN guidelines has added some strategies. And maybe about a year ago or 2 years ago, PanCan had, noticed that we're now in the double digits. And this is all comers, 5-year survival as 10%, but still a lot of improvement to be done. So here we look at who gets pancreas cancer, and I tell people it's mostly bad luck. About 10% could have hereditary genetic syndromes with known germline mutations that are associated with pancreas cancer, or some could have familial where they have 2 family members, at least one is a first degree relative. And really, these are just sort of the genetic mutations we really don't know about yet. But most of these are sporadic. And unfortunately, we're not exactly sure all of the factors that lead to this. But some of the biggest risk factors out there are chronic pancreatitis, which has about 6 times the risk, and smoking, which has about 2 to 3 times the risk. And there's 2 main pathways that lead to pancreas cancer. The most common is this Pannin pathway. And about 85% of the pancreas cancers leads down this pathway. And you get, common mutations like P53 and KRAS, et cetera, that are involved with this pathway. But about 15% of precursors to pancreatic cancer are from mucinous cystic neoplasms. And it's interesting, about 5 or 6 million new pancreas cysts are found a year, but about 8,000 of those are attributable to pancreas cancer each year. So we definitely remove and follow a lot more cysts than ever become a cancer. And it's not the main pathway, but definitely one that you should know about. And the unfortunate reality is about 50% of people present and they're already metastatic, and that's a big bummer for patients and for surgeons. And I think this tends to be how I discuss the breakdown with patients, that maybe 10 come in resectable and then 20% come in borderline resectable and unresectable. And this is pretty important in terms of the classification. So when you have a resectable pancreas cancer, we're really thinking about the arteries and veins. And this is the SMV and the SMA. And for a resectable lesion, you should have no arterial involvement, and that includes the hepatic artery and all other arteries. But you can have up to 180-degree or half the circumference abutment of the SMV and still be resectable. And this just shows a depiction on a CT scan. Now, borderline resectable, you can have up to 180-degree abutment of the SMA, but it can't be encased. And then you can actually have the whole SMV be replaced. But the important thing to be borderline resectable in that scenario is you have to have an inflow and an outflow target to do a vein resection. And sort of this last classification is unresectable. And in this category, you have more than 180-degree involvement of the SMA, or your SMV does not have any available reconstruction options. And so again, about 10% resectable and 20% in each of these other categories. So what do we know? And I think, what do we know about pancreas cancer for sure? And I think one is surgery is the only chance for a long-term survival. 2, adjuvant therapy improves survival. 3, radiation has not been shown to have a survival benefit yet. Complications worsen survival, and R0 resections improve survival. And I'm going to show you the data of this, but that's sort of the take-home message for what is sort of proven already with pancreas cancer. And this is a study from Memorial Sloan Kettering looking at 3 decades of treatment of pancreas cancer. And there have been strides that have made, including 30-day mortality, 90-day mortality, 1-year mortality, and length of stay. All of them have had dramatic increases over the last 30 decades. But unfortunately, with the methods things were going up to the 2000s, we haven't had any improvement in survival. So what have we shown to have improvement in survival over time? Well, so, CONCO, this randomized trial looking at adjuvant gem versus no therapy, shows that you improve survival if you get gemcitabine over observation alone and disease-free and overall survival. So really the standard of saying adjuvant therapy improves survival and should be standard of care for pancreas cancer. But then if you look at this SPAC trial looking at, this looks at 5-FU, and we see again, chemotherapy improves survival over no chemotherapy. But if you look at chemoradiation therapy, there is no improvement in survival of that. So really kind of setting the precedent that radiation may not be much of an addition. And there's a lot of reasons to that. And we can't discuss the nuances tonight, but many people debate over this. So we know, adjuvant chemotherapy, good. Adjuvant chemoradiation therapy, probably not better. But what other factors can we look at? And if we look at this SPAC trial, they looked at number of cycles and then timing to chemotherapy, either 8 weeks or 6 cycles. And what they found is actually the time to chemotherapy is not significant, but completion of 6 cycles of chemotherapy is significant compared to 1 versus 5. And that's been shown actually since this study over and over again. So it's not only getting people to adjuvant therapy, but getting them their complete adjuvant therapy. And then what else matters? Well, here, this looks at, gemcitabine versus GemCape, and they did see an improvement in survival with GemCape over gemcitabine. But interestingly, in this study is if they break out the R0 resection versus the R1 resection, that only the R0 resections receive the most benefit. So again, showing you that, this is another precedent to strive for, in treating pancreas cancer. And this is a summary of SPAC trials. And I bring it up here to kind of show you the survival. A lot of these around 16 to 18 months, and this GemCap a little bit higher at 28 months. And we're going to come back to that in a second. But before that, I want to talk a little bit about R0 resections. And here's just a picture of the SMV. You see here, you see the SMA around here, the first jejunal. And so this is really what we call the vascular groove. So when you're looking at this 3D from your specimen, there's going to be this groove where the vascular surface is. And what the pathologists do is they slice through this and look at these margins here. And with the AJCC 8 guidelines, that you have to have greater than a 1 millimeter clearance between the border and your tumor to be a negative margin, where in the AJCC 7, negative was negative. So you could have within 1 millimeter and still be a negative margin, but the survival is much different. So the staging system has followed suit. So then really a landmark trial that came out about a couple years ago now is this FOLFIRINOX versus gemcitabine. And so that's the hot ticket item now, this FOLFIRINOX for pancreas cancer. And what you see here is 54 months versus 35 months. So really much better median survival than any of those studies before. And, you know, this 35-month survival from gemcitabine is a really deviation compared to the 16 to 18 months I showed you before. But that's because patients were allowed to cross over from gemcitabine to FOLFIRINOX once they recurred. And so really this being a little bit higher is due to somewhat crossover for FOLFIRINOX. And there's a lot of different things in terms of who was selected for this trial. But again, this is sort of the best evidence leading out there to what's the standard of care and the state-of-the-art care of treating pancreas cancer. And so, shouldn't this be simple? Should, well, you just have pancreas cancer, you get 6 months of chemotherapy, you don't get less than that and get FOLFIRINOX. And unfortunately, as I'm sure all the HPV surgeons here wish is that they wish they could get all their patients to that. But essentially that's not typically true. This is a paper from Hopkins, one of the biggest volume pancreas centers in the US, and only 54% of their patients received adjuvant therapy. So when you look at national database studies, it's really a lot lower than 54%. And sometimes people don't get it because they weren't referred, because they don't want it. You never really know. But also patients with complications, don't necessarily make it to adjuvant. And if they have complications and no adjuvant therapy, their survival is a lot worse. So if you see here, they had no complications and they had adjuvant, they have the highest survival. They have complications and no adjuvant, the lowest survival. So really both these complications and adjuvant therapy are independent predictors of survival. And so how is this paradigm changing? If we can't really get everyone to get 6 months of adjuvant therapy, what are other things that we can do? And really there's, a few landmark studies in metastatic disease. This first one was sort of laid the way from GEM over 5FU for pancreas cancer. That's what people were doing for about 2 decades. But about 10 years ago, these 2 studies came out showing Gem-Abraxane as improvement over GEM and as well as FOLFIRINOX. And that really set the stage for neoadjuvant therapy. And so how do we monitor patients on neoadjuvant therapy when they get this before surgery? And really right now, CT scan and CA19-9 are the main things to do. There are other things on the horizon that are not quite prime time, but hopefully will add to what we can do in the future. But then the next question is, not only how do we follow it, but how do you treat it? And, a study that was just published about a year or 2 ago, the SWOG trial, looked at FOLFIRINOX versus Gem-Abraxane. And prior to this, most people tried to do FOLFIRINOX if they could, because there's really, equipoise about which one was actually better. And what this trial found was that, the 2-year survival was equivalent, the overall survival was equivalent, and the disease-free survival was equivalent. So they didn't really show that one regimen was better than the other. And what they showed was that 84 and 85% completed chemotherapy. So that means 15 to 16% dropped out for whatever reason. And then 73 and 70% were resected. So there were about, 30% of people that didn't make it to surgery. And, it's, the question is why they didn't make it to surgery, and, how do, we get people to do better? And really one thing to always remember when you think about these trials and whether neoadjuvant is better or not, is that a lot of studies look at people after they went to surgery, and they kind of lose that denominator of the 30% that didn't go. So one of the first studies that ever randomized people at the diagnosis to surgery versus chemotherapy was this PREOPANC trial from the Netherlands. And, unfortunately, these trials take so long to accrue that now you're looking at gemcitabine. And I just told you FOLFIRINOX was the bee's knees. So, your initial reaction is to say, what do we do, now in this modern era of chemotherapy that gemcitabine is a little bit, sort of old school. So this study showed a couple things. One is that overall survival was equal. The disease-free survival favored neoadjuvant, and then the R0 resection favored neoadjuvant. And really, when they broke the trial down between resectable and borderline resectable, most of the benefit was seen in the borderline resectable arm. But this set the stage, for this. And right now, there's a study that just started accruing in the US using the FOLFIRINOX. There's an alliance trial. Many studies are part of it. It's being run mainly out of MGH. And you're seeing essentially that they get about 8 cycles and then surgery, or then surgery and then 12 cycles. So 2 cycles is 1 month. So essentially this completes the 6 months of chemotherapy that those previous studies have shown. So what are the benefits of neoadjuvant therapy? Well, it's been shown to decrease the T stage, decrease the end stage, increase R0 resection. And this is the only thing that's actually been shown in level 1 evidence of a randomized trial. It's shown some better survival, but the caveat is the denominator of who did not make it to surgery. But I think also very important is it weeds out early progression. Those patients that are recurrent a few months, if you recur on FOLFIRINOX, you're going to recur after a major operation. That's a huge stressor on the body. But I think also for surgeons is less fistulas and less complications, because fistulas drive a lot of complications. But when you have a gland that becomes harder, bigger duct, and has seen chemotherapy, we've seen a lot of less fistulas and less complications in this group. And so, just importantly, how complications keep people from getting adjuvant therapy. If you look at this person who has surgery first, major complications versus neoadjuvant surgery and no resection, the survival is equal, whether they were operated on it or not, which is pretty mind-boggling. This is a study from MD Anderson. But if you look at a patient that had surgery first and no major complications, or neoadjuvant therapy and major complications, their survival is better. So thinking about complications in terms of survival is another key way to think about how to maximize survival benefit for pancreas cancer. So now probably for the part you've all been waiting for, I'm going to show you some videos of some robotic cases. I really break my Whipple down into about 7 main steps, and I'm going to show you sort of the meat of the vascular resection step. But I mobilize everything, the stomach, the colon, duodenum, et cetera. Then I do my portal dissection, and then I'll essentially do the uncinate retroperitoneal dissection. I do my gallbladder last, and then my reconstruction. So here I'm going to show you video of sort of that uncinate vascular section. So you can see here, this is the duodenum, this is the pancreas, the SMV is over here. And this is basically the root of the mesentery. You have your colon mesentery, and you have your small bowel mesentery, and then you have your pancreas. So you're kind of unlocking the secrets there. And the first thing I go for is I want to find the SMV in its course, and then find the gastroepiploic vein. And I always really clear off above and below the gastroepiploic vein before I'll take it. And that's sort of the first step towards kind of really unfurling all of these mesenteric structures from the pancreas and from the vein. So I like this hook a lot. Some people like scissors, some people like vessel sealer, but the hook's my favorite. And that third hand is always showing exposure. So it's really trying to pull the artery out from under the vein, because usually the artery will sit a little bit to the patient's left. So we want to pull it to the patient's right. So once I get around this vessel, I typically take it with a ligature, but if it's a little bit too big, I will either use a stapler if the angle is good, or I will tie it and then clip it. But again, I really trust the energy devices, and as much as I can, I use the ligature. But if it seems a little bit, the vein is a little bit bigger than the width of the ligature, then I may use something else. So again, a lot of this is just sort of that mesentery of the duodenum that you're really trying to get up and pull off of the SMA. So I'll really use my hook to skeletonize the blood vessel. So once I find that gastroepiploic, I'm looking for the first jejunal, because it's gastroepiploic, and then more posterior is going to be first jejunal, and then more cranial is going to be SMA. So that's going to be sort of the secret to my vascular dissection. And here I'm really delineating that I think this is the SMA. And so once I get past that first jejunal, the next thing I want to do is get on the artery wall. So there's usually these little branches that come off of that I take with a ligature, and you could see me showing my my resident where to buzz. So now that we're past the first jejunal, I'm looking to get on the lateral wall of the SMA. So I'm trying to thin that out and delineate it. Look for where the first jejunal, the inferior pancreaticoduodenal vessel may be. And you see here like a little branch off that SMA coming there. So again, I keep readjusting this third hand to keep giving tension and hang all these structures. So here you can see nicely the SMA, the SMV, we're looking to see here, there's this first jejunal, and there's actually a branch coming down, to the mesentery. So there was like a first jejunal artery, which I'm keeping here. And then as I go more north, I'm finding the inferior pancreaticoduodenal artery. You can see me showing the resident there where to use the ligature. And so once we come past that SMA, the next structure I'm going to be looking for is, we call this the vein of Belcher, just named after John Cameron's PA, but it's the superior lateral pancreatico-duodenal vein. And this is sort of a big vein. It's usually at the end of the resection and it goes posterior. So you always want to kind of find it before you get into it. And here, you know, we're dissecting underneath the vein. And then the artery has already kind of made its turn towards the aorta. So this is just, you know, to try and get, you know, as much lymphadenectomy as you can. But essentially, those are kind of the key vascular elements to doing the dissection of the retroperitoneum. The porta is a little bit different. And, you know, in the interest of time, I hadn't put porta dissection here, but if it's something, you know, in the panel discussion we want to see, I could certainly bring up some video and show us a portal dissection. But here's sort of the finished product. We see the SMA over there, the SMV, the SMA on the other side here, the first jejunal vessel. And here's even an artery, a mesenteric artery coming posterior off the SMA to the mesentery. And then up here, you see the hepatic artery in this area, the GDA right there, and the bile duct. So again, that's sort of a lot of the vascular resection. And we talked a little bit about vascular groove, and you could see where this is what we're looking at for our margin. And so we're gonna jump here to distal pancreatectomy. And then I break the distal pancreatectomy into about 3 steps. I consider sort of the mobilization as the first step. And really that's where I mobilize the greater curvature of the stomach and lift that off the pancreas. I mobilize the splenic flexure of the colon, and I move that off the kidney and off the pancreas. And then once I have that mobilization done, I'm focused on the pancreas in terms of, you know, in terms of parenchyma, artery, vein, and then lastly, the retroperitoneal dissection. And I chose this video where it goes into a little bit more detail on the retroperitoneal dissection during a distal. And here is a video. We see the GDA, the hepatic artery node. We see a body tumor right here. You know, it's a little bit fixed here in the retroperitoneum. And this is after the resection where we see the venous confluence, the SMA. This is a typo. That's the left renal vein in that area. And then we'll kind of look over here where we see the left adrenal, and then we see some renal arteries coming off. This is the left renal vein, and then that's the SMA as well. And then over here in a second, we'll see the kidney. So we've taken Gerota's fascia off the retroperitoneum and have the spleen. So first thing we'll do is get around the neck, creating a tunnel, and then take the neck there. The next thing, you can see the celiac here, the hepatic artery, the splenic. We're test clamping before we take that. And then we get around the splenic vein. And then once we get around that splenic vein, then, you know, I just take all of these things with a stapler. And then this is sort of the difficult part of this dissection, is that it's really close posterior. This patient's gotten both chemo and radiation therapy. I know I kind of told you there's no data for radiation therapy. So when I use the radiation therapy is when I have a tumor that's got about 180-degree abutment of an artery, where I will have them radiate that arterial surface in order to hopefully have an R0 resection. So here we're kind of digging out the renal vein and the adrenal gland. And this is, you know, what we call like a RAMPS procedure, where you're trying to take out as much retroperitoneal tissue as you can in order to have a negative margin. And again, I like a combination of hook and ligature. So usually on the ligature, depending on who does the case, it's either me on the ligature if I have a fellow doing the case, or you know, it could be the resident if I have them doing that. And so, you know, what is sort of the best evidence of minimally invasive pancreas resection? So about 2 years ago, former now, I guess since the meeting was about a month ago, president of SAGES, Horacio Osben, really had a Herculean effort organizing a multi-society meeting. You know, they had, you know, SAGES, SSO, HPBA, you know, international societies, et cetera, all coming together going through these minimally invasive guidelines, and so for the distal pancreatectomy, what these guidelines showed was that for distal pancreatectomy for benign and low-grade malignant tumors is to be considered over. So the standard of care over open, since it is associated with both shorter hospital stay, reduced blood loss, and equivalent rates. And that was a 1B, and sort of how basically, whether it's a strong recommendation is 1 versus a weaker recommendation is 2. And then A, B, C is based on sort of levels of evidence. So this is pretty good evidence here. And then, prospective data about cost effectiveness is limited. So that's sort of, weaker and not a lot of data. MIDP is associated with better postoperative quality of life. So there's a little bit more data, but not a lot. So it's a weaker, but better evidence. And then MIDP for pancreatic ductal adenocarcinoma appears to be feasible, safe, and oncologically efficient technique in experienced hands, although prospective comparison studies are lacking. So, there have been several randomized trials, and there's some still open, that have shown in laparoscopy. There haven't been randomized trials in robotic that have been head-to-head yet, although probably you'll see some in the future. And then what about for Whipple? So there's a lot less evidence for Whipple. And then as an aside, so if you were to look at the NSQIP database, just sort of that encapsulates many different centers in the United States. And if you were to just query, distal pancreatectomy, minimally invasive, you'd find that over 50% of the distal pancreatectomies in the U.S., at least in patients that are NSQIP or hospitals that are within NSQIP, are going to be done minimally invasive fashion. But if you looked at that for, Whipple, you're more at like 8 to 12%. So a lot less are being done minimally invasive. And actually, most of these are being done laparoscopic. I would say that probably 2/3 to 1/3 laparoscopic over robotic, but certainly the robotic is growing and the lap is decreasing. But, the data for the pancreatic duodenectomy is not as strong. There is insufficient data to recommend one over the other. Centers performing minimally invasive should be including all of their outcomes data into national and international registries and prospectively maintain databases. And I think that's important. And I think national registries are important because you have a lot of single institution studies that may say, this is great, everything is better, but that may not be reducible at every center. So really, when you look at some NSQIP or NCDB studies, people aren't able to hide their outcomes or only publish positive studies. And you really see a good sense of the denominator and some of the other sides of things. And then so next is both MIPD and OPD are valid approaches to patients and no comparative data after neoadjuvant therapy. And that's just sort of expert opinions. And there have been, several lap versus open pancreas trials, no robotic, but pretty soon, so they had, at least out of the Netherlands, they had, the Leopard 1 trial, which was lap distal pancreatectomy showing, distal was better. The Leopard 2 trial was the lap Whipple, and they actually closed it early due to non-significance, but a trend towards higher mortality in the laparoscopic arm. So actually in the Netherlands, they don't do laparoscopic Whipples anymore, but they have started doing robotic Whipples in 2016. And I think they're looking to open a Leopard 3 trial, which is going to be robot versus open Whipple clinical trial. So again, I'd like to thank SAGES for the opportunity to present tonight. Happy to take any questions. I'd like to thank my previous partners at Pittsburgh and previous fellows like Dr. Secunde, who's such an all-star, and then my current partner, Dr. Telemani.
Perfect. Thank you very much, Melissa, for a very insightful talk. And I think the study that you mentioned, I think all the fellows should be very familiar with all the trials that have been out there for pancreatic cancer, neoadjuvant, adjuvant, and a role of radiation and everything. I think those are very, very, very important studies to know. Now we have all our speakers have given all the talks. So we're gonna open the session. We have about 15 minutes before closing time. I have recorded a couple of the questions from the audience. So I'm gonna start with Eduardo. Eduardo, there's audience that asks, is there any antigen test for gallbladder cancer? It's like CA19-9, AFP, whatever. Is there anything for gallbladder cancer?
Well, like biliary tract cancer and pancreatobiliary cancer, you can use C99, right? And we can discuss about whether it's sensitive and specificity about gallbladder cancer. And if I review my data, incidental gallbladder cancer, there is T2, T1B, actually C99 is most likely normal. There is also some data about CEA, and so we actually measure both C99 and CEA.
Perfect. A second question that I have for you is, and I've seen this question in the multiple society, is there any guidelines or any recommendation about how much liver you removed? I know there's a portal tract seeding on gallbladder cancer. This is always a debate, how much you take out liver.
The Japanese had a consensus, and it's published in the Japanese Hepatobiliary-Pancreatic Science journal. I think it's a well consensus because there was two schools in Japan, and they have the lead in this. One of those were very aggressive, and you can see some of the surgeons very aggressive for gallbladder cancer, and other they were not very aggressive, and they just did a gallbladder bed resection. So they did a study comparing segment 4B and 5 compared to gallbladder bed resection, and they actually find that gallbladder bed is just does equally than a segment 4B and 5 resection. I do think for biliary tract cancer, the thing is more significant is having an R0 margin, regardless of the amount of volume you got from the liver, and the tumor biology that will probably decide most of the time. And that's the reason why I showed this study from a Japanese pathology that show specifically the way that gallbladder cancer spread in the liver. And you can see that most of the gallbladder does not express directly to the liver. Most of the time they follow what is called the portal tract invasion, and they can actually have a wide satellotosis that can be actually bilateral at the time of diagnosis, meaning it's not going to make any sense to have a major resection while you already have bilateral micrometastasis in the other side of the liver.
Thank you, Eduardo. It's actually, I pay a lot of more respect now to gallbladder cancer since I started doing them, and they're tough disease to cure. Many times they have recurrence, and it is they're very malignant.
I do have to say that the data, the national data, shows that what we are missing here is the lymphadenectomy.
Yeah.
And that's also for cancer like from biliary tract cancer like intrahepatic cholangio. What we are not doing a good job is in the lymphadenectomy, and we are always center the disease in the liver. And I think when it is already in the liver, there's not much we can do. So we have to do a resection of the gallbladder so we can assure an R0 resection there, but we have to focus in a very stepwise approach of the lymphadenectomy and have to do 12, 8, 13, or 16, at least what I do. Some people, I heard some other people think that station 13 it could be like a sentinel node, and if it is positive, there is almost like a 16 station. However, when I review my data and the collaborative data we have, I couldn't power enough to make that conclusion to be significant, because most of the time we don't have that lymph node notice in the study. So I think it's just, I think if you do a lymph node dissection and you get more than 6 lymph nodes, and you do a gallbladder bed resection that get you an R0 margin, that would be enough. And that's all you can do. and everything else is tumor biology. And yeah, we need to work on that first.
Yeah, completely agree with that. Now, I'm going to take the question from the audience. I'm going to move to Subhashni now. Subhashni, there's a question from the audience here, one of the residents, I guess. What approaches are there for biliary injury in laparoscopic cholecystectomy? How do you handle this in your practice?
I think you know the answer. If you're talking to me, I would say you have all the options, but I choose the minimally invasive approach. And even in minimal invasive approach, I would choose the robotic platform. But you can, address biliary injuries, open technique, laparoscopic technique, and robotic technique. Now, this is the thing. Most often when I get referrals for biliary injuries, it usually falls into two categories. Either the person that's referring me has already converted the procedure to open, and then I actually get disappointed. Please don't do that. Send me before you convert it to open. The reason being, we can repair these things, especially in the immediate period. I pretty much use the same trocar sites that they would employ to remove the gallbladder. Maybe an additional port here and there. So that is important, even though that might sound very trivial, that, we use the same ports and just maybe added one. But in the long term, it becomes important because postoperatively, most patients look at that. And instead of having an incision or drains coming out of it or delaying the repair where it is much more complex and the patient really feels the morbidity of it, if you can repair it immediately using minimal invasive approach, even though the severity is same, it's still biliary injury you're repairing. For some reason, the patients don't feel that burden. And that is very important, especially when we are trying to repair the injuries. But of course, the key thing is a good repair, because you're only going to get one chance. So you have to pick up whatever technique that you're solid at in order to repair that. Because if the repair is not done very well, then it doesn't matter which approach you employed. So first, identify yourself what your strengths are, whether you can do it with minimal invasive approach as good as open surgery or even better, then I would offer that. So you can utilize any approach.
Perfect. And
I'm sorry, Iswando, in the SAGES, I can't remember if it was 2018 or 2019, I do have a video of biliary injury repair with the minimal invasive for reference if they want to go to their on SAGES video collection.
Yeah, this is another example that SAGES has a lot of resources, and the video library of SAGES get a lot of technical video and stuff. There's another question for the audience here. How do you make how do you choose between doing a colodoco duodenostomy, colodoco do versus colodoco judge? We're always concerned that there's issues with the food going into the liver and stuff. Doing a colodoco duodenostomy. I saw one of the videos actually colodoco do. Can you comment on that?
Sure. The preference, although the preference is to do a Roux-en-Y hepaticojejunostomy, you have to see, once you do a Roux, it's difficult for an endoscopist to go back. Okay, so you kind of eliminated that access route. So you kind of have to weigh the benefits and risk. Do you want to have access to that biliary tree endoscopically? Okay, if you do, then a hepatico-do might be a good option. But if you think you did a permanent repair and there's no reason for you to go back there, you don't think that the patient would require any kind of further intervention, yeah, you can do a Roux-en-Y and then that would be it. Although saying that, there are still some GI surgeons that can use double balloon and still can go up the Roux. And that's when instead of, for example, if you're doing a Roux for some other procedure, for biliary procedures, I do a little bit I cheat and do a little bit short segment so that they can still enter the biliary tree. Unlike, for example, if you're doing a long segment route, for in this case, I would do a short segment route just because they can still access it with easily. So that would be my main reason. Do we need to come back here again into this biliary tree for any reason? If it is, then endoscopically, most GI surgeons would say they won't be able to access once you say that you did a Roux-en-Y. And then you will end up with a PTC, which is a morbid, compared to an ERCP. So I for that sake, I would do a hepaticoduodenostomy. And the second reason being anatomy. How flexible is that duodenum to come up? And not always you're able to mobilize, especially if you're doing this in an inflammatory setting with thickened duodenum and stomach. That portion doesn't come up as easily as a normal bowels would be. In that case, maybe the Roux is the best option, because then you can bring a segment that is away from this area of infection and inflammation and do a nice healthy repair.
Perfect. You can tell from how Subhashini is answering she says experienced surgeons, she knows the stuff, when the duodenum will not come up, and that can be a problem. You cauterize whatever you want to cauterize, you end up making a hole in the duodenum, and duodenum is still there and doesn't want to move anywhere.
But if you're going into these cases, you have to be prepared to have an alternative options also. You can't just set your mind and say, I'm going to do a hepaticoduodenostomy. May not work.
Yeah. So moving on for Melissa, I see some questions here from the audience. I think it's important to kind of give them a brief overview. They're asking about the timing spent in the OR, open laparoscopic versus robotic Whipple, and open laparoscopic robotic distal PENG.
Yeah, no, I think it's a good question. There was a study, a multi-institutional study that we did at Pittsburgh with the CPC, and we had 2 robotic centers, Cleveland Clinic and Pittsburgh, and then we had, there was about 7 open centers, including like Cincinnati, Wisconsin, Vanderbilt, et cetera, all the ones within the CPC. And so this was a pretty closely matched group. I mean, these were all beyond the learning curve, experienced surgeons, et cetera. And, it's about an hour more, for robotic cases in this experienced group than in the open cases. I think about 70 minutes. So that's probably the best study that you can see, sort of robot in that regard. I think for distal, there's not a great comparison. I would say that, in our single institution Pitt studies, robot were some of our fastest cases, but, you could imagine that there's some case selection here that's in the sense of, vascular resections being done open or different multivisceral sections. So I don't think with the laparoscopic, or I'm sorry, with the distal pancreatectomy, it's too big. But I think some of these factors are, learning curve related. Because if you look at most of the studies in terms of learning curve, the OR time is one of the biggest factors looked at, as opposed to like complications, et cetera. And, we did a study at Pittsburgh looking at first, second, and third generation OR times. Basically it was like Herb Zay, Jim Moser, and then me and Amr Zerkat were second generation. The fellows like Aswantu, were third generation, and each generation OR times got better. And looking at, the pioneers in 2008 doing robot Whipples, we're talking about 10, 11 hours, and these people were probably doing, 5 to 7 hour open Whipples at that time, and so then when Amr and I started, it was, 7 hour Whipples. And then by the time the fellows, were integrated in it, it was about 6 hour Whipples. So I would say OR time, it's just variable. I mean, if someone's doing their first robotic case, it may take them 12 hours, but that person's probably not done any training, not necessarily mentored some, found a mentor to see how to set up the case. So I think probably about 5-10 years ago, you're seeing a lot of, double-digit cases, but not as much now. And I think there's a little bit more training in residency, in fellowship, et cetera. But I think by and large, most of the studies will show that minimally invasive may tend to be about an hour longer, if not a little more.
And also for the interest of the resident here, because I'm assuming there's a lot of residents fellow here. So, I know a lot of them, they have interest to learn this robotic pancreatic surgery. Can you share with our audience what it takes to get there? I mean, learning curve, you kind of touched a little bit on its learning curve, but in terms of like a training pathway, how can they get there? Because if they want to do a robotic Whipple, they get 1 to 2 referrals. They want to do robotic Whipples. They're probably a bit afraid of doing it. What if this? What if that? And can't control this. So
Yeah.
how to do it best?
Yeah, I mean, I think, first and foremost, what comes before minimally invasive is knowing how to treat the disease and knowing how to do the surgeries, knowing what the anatomy is and knowing how to deal with the complications. So that content, can't be overemphasized because decision making and judgment is like pretty crucial to everything we do. But then when we're looking kind of to add the technical aspect, I think, there's several different layers of surgical proficiency. It's like mastering the instrument, mastering the anatomy, mastering the tissue handling, mastering the sequencing of operation. So there's a lot of different things, different facets of surgery. And I think that, I always start people in simulation, have people do virtual reality, get to levels of proficiency. And that really just teaches the console. And the next level is doing things within an inanimate environment, that are deliberate practice that can increase the familiarity with tissue handling, breaking suturing, moving within space, and then really like video review, like, Sage's video library should be a resource for everyone out there, not only YouTube, et cetera. But I think that the more advanced of a surgeon you get, actually, the more you get out of video. I think when you're younger, you think, oh, I just have to be in there, I have to do it. But really, there's so many pearls you could learn. And, Swatu probably will sometimes never have done a case and go see a couple of videos and be like, okay, I could do that, and so I think you can't underestimate the importance of that. But I think also, I mean, you can't underestimate the importance of mentorship. And whether that's someone at your institution, someone you trained with, someone at another institution, someone you meet at a meeting, someone you meet through Sages, et cetera, is letting go of your ego and asking how someone does this and how's the best way for you to do it, and not appearing like I know everything and I can do anything. And I think really just being humble and realizing you're a student and you're there to learn, and every day is a classroom day for you. Because even now in practice, I'm continuing to evolve and learn more than I knew last year or the year before that. And I think that's going to be the case for our entire lives.
Yeah. This has been a very great discussion. We are actually past the time now. It's 9:03. So I'm sure there's a lot of other questions that the residents want to ask, but I think we have time limitations here. And I want to ask Brian, is there any closing remarks, Brian?
I just encourage everybody to join Sages as a candidate or full member, and then look for training courses in laparoscopic conduct exploration to come in the near future. Thanks everybody for joining. Great turnout, great speakers. Really appreciate everybody's input.
Have a good night.
All right. Thank you very much, everyone. Thank you very much.